talking about updates in breast cancer diagnostics. Really important conversation. I'm so glad you're with us today. I do have a few housekeeping notes before I turn it over to our awesome panel. But first, I'd just like to say hi. I'm Nicole Owens. I'm the Director of Marketing Communications for MassMEDIC. If you're not familiar with our organization, we're a membership-based trade association for the med device industry, working to bolster the industry primarily in New England through education and connection, so events like this, awareness, and advocacy. I do have a couple sponsors I would love to give credit to for supporting our Women in MedTech Forum this year. So I'd like to say thank you to Medtronic, Best Buy Health, PA Consulting, and Sunrise Labs. This webinar is recorded today, so anyone who registered will get a copy after the conversation concludes today. And we are going to have time for Q&A. So if something comes up that we haven't hit on yet, please feel free to put it in the Q&A function at the bottom of your screen, and we'll do our best to answer it live. All right. Without further ado, I am pleased to introduce our panel for today. We have an amazing lineup of rock star women who are in the imaging space doing some awesome things. I personally am an 8-year breast cancer survivor, so I am so excited to bring you this content today. First, we have Elizabeth Cormier-May. She is the CEO from Mammograms. We have Marissa Fayer. She is the CEO of DeepLook. And we have a slight change to the agenda today. Dr. Jyoti Gupta unfortunately had a conflict at the last minute, so we are so honored to have her colleague with us today. Celeste Slade, she's the clinical leader and product manager of advanced applications in breast health at GE Healthcare, has over 25 years of experience. And I'm going to turn it over to her first to introduce herself and tell you a little bit about what she does at GE.
Great. Thank you, Nicole, and thank you everyone for joining us and having me. I apologize for Jyoti not being able to join us as well. So honored to be here. Yes, I've been working in breast imaging for about 25 years now and had a real great honor to see breast imaging come as far as it has, and look forward to the discussion today of all the other work that's being done around technologies to really help to not only screen and have precise imaging, but also rapid diagnostics. Early detection is so important in this to affect clinical outcomes and survivorship. And those are some of the things that we're looking at GE Healthcare, all the way through to treatment, diagnostics, et cetera. So look forward to the discussion. It's a good time to have this discussion with a lot going on in legislation. October coming up as breast cancer awareness. And yesterday happened to be World Dense Day. So breast density day. So thanks for having me.
Thank you so much. Marissa, would you say hi?
Hi, Marissa Fayer, the CEO. Oh, sorry, there it goes. Marissa Fayer, the CEO of DeepLook Medical. And we're a software technology imaging company focused on software that overlays onto existing imaging. So we're not displacing anything. So we work with all of the existing imaging that's out there. And our specialty is that we can visualize at a lesion level, very specifically in dense tissue, which very here to this discussion means dense breasts, liver, lung, thyroid, all those other things. So yesterday, of course, was a big day for us for World Dense Breast Day. And we'll talk about a lot of the, updates and legislation and technologies and things like that. So it's great to be here. I've been in breast imaging for, oh my God, over 20 years. Originally, I was with Hologic for a very long time, developed the 3D mammography system. So I know the space. I'm excited to be here.
Thanks so much, Marissa. I'm glad you're here too. And Liz, would you say hi?
Sure. Hi, everybody. I'm Liz Cormier-May. I'm the CEO of Mammograms, and I'm a little bit different than my lovely co-panelists here. I actually focus in the diagnostic space. So at Mammograms, as well as our sister companies, everything we do is focused on early detection. We presented our first round of compelling data last year at San Antonio Breast Cancer Symposium. We are very different in the fact that we're very transparent around our stage 1 data, primarily and very specifically, because as Celeste said, early detection is everything, especially in the breast health pathway, when so many of us are so good about going to get our screening, but we're still diagnosing really late. leaving treatment options somewhat limited. So at Mammogen, we can detect stage 1 breast cancer from blood with 99% sensitivity and 89% specificity, which completely changes the way women can take care of themselves, and especially us dense-breasted women who right now have somewhat limited options. And so Mammogen is here to place ourselves alongside the leaders in imaging and make sure the right women gets to the right intervention at the right time.
Awesome. So important. Thank you as well for being here today. All right. To kick off today's conversation, I really want to start talking about what the standard of care is today. What's recommended for women and at what age? Celeste, could you kick us off with that question, please?
Yeah. So I love what Liz is talking about. I wish the standard of care was a blood test at this point. I mean, it just sounds amazing. But our standard of care today and recommendations are that all women start screening with mammograms at the age of 40. And we just had that updated. All professionals and specialists in this field have always said 40. They've always said women should have their mammograms every year. The USPSTF finally came out and updated their recommendations to be 40. Unfortunately, they're still saying every other year. That's not enough screening based on all of the evidence that is out there, and particularly around this issue of dense breasts. Sensitivity of mammo as a standard of care for everyone is wonderful, but as our breast density goes up, the sensitivity of mammo goes down. So we do need personalized imaging, and I think that's some of the things that we're going to talk about today. Of where do we go for dense breast women for imaging, as well as other technologies out here. But today, luckily, 40 years old, some would argue we need to do some testing earlier, particularly for high-risk patients. We are finding cancers in younger and younger women, and it is a serious problem. Breast cancer is the #1 indicated cancer in the world. And, for all intents and purposes, our #1 risk of getting breast cancer is just being a woman.
Yeah, fun times. I was 36 when I was diagnosed. So yeah, definitely recommend people start early. So let's dig into that a little bit more. Liz, if someone does have a family history, if they're at higher risk, should they be doing anything different?
Yes, they should be doing things differently. If you have a family history, especially if your mom or your aunt or your grandmother was particularly young, that's mostly defined as 50 or under. If your family history happens to interweave breast cancer at earlier ages, and you should be getting screened before 40. And Celeste kind of got to this point that there's not a general consensus, but you need to start advocating for yourself if you know you have a family history, especially if it's in younger relatives. As soon as you're seeing an OBGYN, if that's at 18 years old, start advocating then. Start sitting down and having the conversation with your providers, letting them know you're aware of your family history. It happened particularly young. If you know you're a BRCA carrier, you need to be having these conversations as soon as you're seeing a women's health specialist. For most of us, that's somewhere, late teens, early 20s, and it's our OBGYN. Start having the conversation with her and him. And then you will fall into, it's usually a shared decision-making pathway, but at least once a year, ladies, if you have a family history, at least.
Yeah, but I would also like to say that only between 10 and 20%, I don't know the exact number, of breast cancers are because of family history. And
Yes.
so if you feel something, like you have to do your self exams, like we look at ourselves in the mirror and be like, oh, there's a wrinkle or there's a mole or something. But you also have to do your self exams every year, every month. And if you think something's different or feel something different, that's when you also need to advocate, and you need to start that again, 18, 20 years old, so that you know what's norm and that what the differences are, because we can't simply rely on family history. That family history absolutely, increases your odds at an astronomical rate, but it is not the only, precursor for developing breast cancer. And so you have to know and take control yourself.
Yeah.
Well, I think that's why it's so important too that, the Preventative Service Task Force has changed their recommendations to 40 because they're the ones that our referring physicians are listening to.
Hmm.
And if they don't have the right recommendations based on experts in the field, then women aren't going to be doing this. And Marissa, you're right. I don't know the percentage either, but family history is
15%,
absolutely
15%.
50%.
15.
Is absolutely a factor, but dense breast is just, another. And we're seeing so many new women getting breast cancer that have no family history.
Well, I mean, 71% of all cancers happen in dense breast women, which affects 45% of all women. And actually, they think it's higher because that's only being reported for women who are getting mammograms and things like that. So much younger
Right.
women, your breasts are typically denser when you're younger. And I know I'll get to this soon, but they're younger, and you could be at 25, God forbid, 36, like you, Nicole, and you have dense breasts and you found it.
Yeah.
I did. We've shared this story before, but I found it myself and I didn't have a family history. So, the numbers are right. Marissa, you hit on something really valuable, I think, and Liz as well, that, being your own advocate. I love that. You have to, be your champion. But Marissa, you also said you have to know your own body, you have to do your self checks. What else should people be aware of? Because there's other signs of breast cancer besides just lumps. Can you share, or anybody, what else should people be looking for?
Yeah, I mean, a few of them are a discharge in your nipple, dimples, if you start seeing dimples in your breast, or, changes in shape, things like that. Also on the side, you can feel things in your lymph nodes sometimes. Now, listen, after your period, you're almost always going to have a swollen lymph node. But if it's not right after your period, and you still have it, and it's months and months and months, if it's a longer duration than 2-3 days after your period, that's something to have a doctor take a look at. And you can go to your PCP, go to your OBGYN, have them check it out first before you think it's the worst. It could also be an infection. It could be so many other things. So I mean, you have to look if there's visual deformities, and a lot of times, like, you might feel something, and I'm sure that there's other signs as well. So I'll let the others.
Look out for rashes. A lot of people don't know this. Rashes on your breasts can be a hallmark sign of breast cancer. And especially most of us ladies, as professionals and wives and moms and partners, a rash can be something that's easily just, oh, it's a rash, that's annoying. But pay attention to these things, because you're your body better than anybody. And if you start to read different organizations and the ACS still says that we shouldn't be checking our breasts. That's ludicrous. You absolutely should know your breasts. You should be checking them every month. The vast majority of breast cancers are found by the women themselves, right? So we need to make sure that we're paying close attention to even what might seem like a small or trivial change.
Yeah, thank you guys so much. I'd like to talk a little bit about what if you find something, what if you get a suspicious mammogram? What are the next steps? What are the next technologies that you might leverage in order to get a diagnosis or rule out a diagnosis, hopefully, right? Celeste, could you talk a little bit about that? What other technologies, imaging technologies, might people come into play with?
Yeah.
Like that.
Certainly, additional views of mammograms are normal to do that. Ultrasound is very normal to rule out cysts, because we may feel something, they may see something, but a very normal cyst can show up very easily in ultrasound. And then there's higher sensitivity exams such as MR. MRIs are very widely used, well recommended by NCCN, ACR, all of the standards of care of where a patient would follow, particularly when they're higher risk. As we've been discussing here, just dense breasts and being of a higher risk, recommendations are that you have additional advanced imaging or have some sort of imaging every 6 months. Now, the challenge there is women are not compliant. 50% of women aren't even compliant with doing their screening mammograms. And then we look at women going for MRs, and about 43% of them specifically are not coming back for those MRs. So we're always looking for new technologies to figure out how we break barriers to access. Where are these MRs? And then also cost of care. MRs are very expensive, and we'll talk more about this because insurance coverage is, a lot of insurances do not cover out-of-pocket costs for diagnostic exams, including MR. So how do we bring more technology? Mammogram systems tend to be all over the place, more accessible in the community where women are. New technologies such as contrast enhanced mammography has been gaining a lot of momentum. It's been out for years, but it's gaining a lot of momentum now as it's gotten out of the academics and into the imaging centers because it is so accessible. It has a high sensitivity. See that vascularity where cancer starts its blood source very early. And it's a mammogram. So it combines a couple advanced applications with technology that's more accessible out there. And comparatively out-of-pocket costs are low, but we do need to figure out how we can make diagnostic imaging more affordable and accessible.
Yeah,
because it's not today.
really good points. So what's the difference between a 3D mammogram and the image contrast that you mentioned?
Oh, so I think Marissa designed the DBT system, but you know, it's an X-ray, right? So you're taking multiple X-rays across the breast for a DBT, and we all call it a 3D mammo. It's really not a 3D mammo, but it's a dimensional mammo, and you can see around the corners, right? Eliminate that overlapping tissue, and which is truly helping to reduce recall rates, so women aren't having to come back. Where the contrast comes into play is we do an injection, just like you would in CT, very tolerable and accepted, very stable material. And then you wait 2 minutes, get some flow through your body. And then you just do a 2D mammogram. And under that one compression, we basically do a subtraction. And what you're left with is the vascularity, again, the highlights of where cancer may be developing very early. And it takes away that morphology of the breast. So, you know, one of the biggest challenges around dense breasts is dense breast tissue shows up white on mammograms, and cancer shows up white on mammograms. So it's that masking effect. So not only are you at a higher risk of getting breast cancer because you have dense breasts, we're also at a higher risk of missing your cancer in dense breasts using mammo alone. And that's why some of these additional screenings are so important. And if women can't pay for them, they're certainly not going to get them.
I see you came off mute, Marissa. Do you want to add anything about dense breast? Obviously, we have to talk about it. It's an elephant in the room, right? And there's lots going on, you know, in the public view as well with dense breast. But, you know, so Celeste just said it shows up white, so it's cancer. Obviously, that's a big issue. Is there anything else about dense breast?
So, you know, and I don't want people to be like, oh, well, you know, I'm skinny, so I don't have dense breast. It has nothing to do with your weight, your body composition. It is simply the difference between, you know, fatty tissue and muscular tissue. And there's literally nothing you can do about it. The only thing you can do about it is age. That is the only way it's going to, you know, potentially get less dense. So it is genetic, disproportionately affects Asian women, Black women, and Jewish women, or women with, you know, Jewish descent. And quite honestly, you know, that's probably 70% of the world. And so just depends your body composition. You cannot, you know, diet away, you know, healthy eat away dense breasts. It has absolutely nothing to do with that. So like, please don't think that because you're of a certain body composition, you don't have dense breasts. Ironically, a lot of people with very slim bodies have dense breasts. So there's that component. Certainly the issue with it is that on a mammogram, like this is just how the systems were designed. And of course, you know, like Celeste said, I was part of, you know, the 3D one, and all it is 2D just knitted together. We call it 3D, and you know, that's why it arcs around you, because it's taking all of the extra images and it's trying to you know, it's AI, it's tech, it's, you know, software that's overcompensating and knitting it together, just like in an MRI machine and a CT, you know, you see it on the fancy TV shows where they're like putting up this heart that's all, beautiful. It's very similar. And with dense breasts, that tissue shows up white. And it doesn't have to be homogeneous white, like, my background or anything. It could just be pockets of white, and pockets of density. And there's different ratings, A through D. And that's just a scoring system that the radiologists use to determine your level of density. Now, thank God, on September 10th, every single woman who has a mammogram will be alerted if she has dense breasts. Now it is a national standard. It used to only be in 33 states. Now it is national, but that means you get alerted and you still, potentially, as Celeste was saying, have to pay for it. So there's a lot of work that we're still doing around that. But when we talk about breast density, you need to have, and we don't like to say supplemental imaging anymore. It is necessary, important, additional imaging. So you have to have your screening mammogram, that's first. Then you have to go out, have an ultrasound. You might have to have a diagnostic mammogram if neither of them can, rule out, and that's a very specific area. Maybe an MRI, and then, potentially a biopsy. And really what needs to happen is there needs to be technologies that can, see inside the dense tissue to potentially alleviate or eliminate any one of those, next imaging tests. Celeste was saying the facts, like 50%, 43%, like people are not coming back. They're not even getting their general mammograms, let alone secondary imaging. And it's hard, and women are busy, and professionals and, caretakers and mothers and multiple jobs, and might not have access to a lot of the services. And quite honestly, some of them are very expensive too. You might be allergic to some of the dye with a contrast enhanced, mammography as well. Like there's so many complicating factors. And so this is really where tech starts to come in to help the existing imaging that is already there, because I am going to say it's great. And there's other tests that, I know Elizabeth is working on, and others that are working on, that will be supplements. Now, I'm not saying mammography is going away, because I really actually don't ever think that it will. And it is the standard of care, and it is a workhorse. I mean, it's a great technology, and, just for a very large segment of patients, there needs to be additional.
So today we're talking about all the cool technology, right? That's what Women in Med Tech is about. We're all in the industry. We all want to know what's coming next. Is Deep Look a potential solution that can help, complement some of those? How does that work?
It is. What a good
Tell us
question.
more. Tell us more about that. And can you ask for it? Where is it?
Yeah, so we've just recently gone commercial, and it is a technology that overlays, like it is seamless to a patient. Patient wouldn't even know if it's being used. It is a technology for radiologists to visualize and help in dense breast tissue. There's an area of question. They, click on it, and the radiologist takes a deeper look. There might still be, we're not saying we're eliminating other additional tests, but it could potentially rule out an area that just you cannot see through, and you want to just take another look. And so the software is available. Please ask for it. Ask your radiologist for it, because then they need to order it. But please keep asking for it, and tell us where you are, and we will send our partner sales teams to it. It is simply for the radiologist, it's like an app to download on their existing monitor, because that's who our partners are. And so it's an add-on, and there's other technologies. There's technologies that are doing the identification of areas to look at. There's other technologies that are there specifically to do scoring and density and triaging. At Deep Look specifically, we look at the lesion. We're an aid to all the other technology that's out there, and because we can visualize at a lesion level in dense tissue, it's simply an add-on with no additional cost to the patient. And so, yes, fully ask for it, and we would love it. We've just gone commercial, so currently it's in several New York hospitals. We are rolling this out nationwide. We're also so we're FDA cleared. We're also cleared in the UK, in Canada. We're working on Mexico and Israel, and we will be going to Europe shortly as well.
Awesome. Great news. Congratulations. Liz, I saw you come off mute. Do you have something you wanted to add to that?
Yeah, sure. So I think it's really important for people to understand that up until now, any type of diagnostic intervention outside of imaging has been either completely, relatively, or entirely unavailable in the breast care pathway. And I think that we're at a really important moment in time, not just because there's diagnostic companies innovating, but because I think we really need to talk about what happens in the wake of MQSA, right? We have so thankfully, for the first time, it's now, as Marissa said, a national mandate, and every woman who gets a mammogram is going to be told of her breast density category. That is wildly important. I have a very dear family friend who is 75, who I told to ask about her breast density because she had no idea. She had never had a conversation about it in 75 years with her provider. And last year she found out she had dense breasts for the first time at 75. How does that even happen? That's wild, right? So in the wake of this massive influx of information, I think there are some real practical, logistical questions that we all need to start to ask ourselves, right? Not just for women who may not be able to get to an imaging center, but for the imaging centers that are mostly already reaching capacity. How do we supplement the existing standard of care pathway? And I think that's where blood-based diagnostics become so wildly important. And I think it's really also important to understand that, for those of us, so I'm one of those women, every 6 months I go for my ultrasound. Sometimes the MRI gets thrown in there depending on what they see and what's happening. And what's really important to understand is, as those technologies are incrementally more sensitive, which is why they're giving them to women like me, right? But I really do only mean incremental. I mean, they catch additional 2 to 14 cancers per 1,000 women. So if we start to think about what happens when potentially millions of women are being pushed into a care pathway that they didn't even know they should have been a part of for the last X amount of years, in an already very crowded healthcare pathway, how do we most effectively add in diagnostics that do 2 very important things? One, help diagnose it when it's there with real high accuracy, but also keep women out of pathways that they don't need to be on. What's going to happen? How many women are going to be getting breast biopsies because they're put into a pathway? And while MRI and ultrasound are more sensitive, they're far less specific. So they may see something, but they don't know what that something is. Is it a dangerous something or is it a benign something? And then you have to go on a biopsy to answer that, right? And we know right now, 80% of all breast biopsies are benign. So how do we simultaneously solve those 2 problems, knowing there's going to be an influx of women coming into a care pathway? And that's where I think diagnostics are going to play the most important complementary role to imaging, because we have to have access. We have to keep costs affordable. We have to make sure that every woman who, whether lives next door to an imaging center or is 4 hours away in some part of Oklahoma, has access to something. And if you can walk into a local lab and get a blood draw and get results with extremely high accuracy on both ends, both yes, you have it, no, you definitely don't, then we can start to make a real impact, I think, in this care pathway. And we haven't talked a lot about this yet, but particularly in breast cancer, finding it early could be the difference between a mastectomy and no mastectomy, chemo and no chemo, radiation and no radiation. And we always say our goal at Mammogen is not to detect disease. There are plenty of people who detect disease, but it's to preserve the quality of life for a woman as close to the day before she found out she had breast cancer as it's humanly possible. And so to be able to pull women out of necessary treatment because they didn't find it till stage 3 and stage 4, giving them options at stage 0 and stage 1, I think that's going to become increasingly more important, and it should be something we're all talking about far more than we are.
Yeah, and survivorship. I mean, 99% of women, when you find it early, stage 0, stage 1, are surviving for over, the stats are for 5 years, but, obviously much longer. But 99%, when you find it early, that's significant. So, even the costs of the healthcare system are much less. There's much less radiation, much less chemo, much less treatment, potentially not even surgery. There's all of these things that reduce the healthcare system. And that's why, everyone talks about breast imaging, and we're talking about it here, and why there's so much technology associated with breast imaging. In reality, it is the only annualized screening that happens, honestly, for anybody really, in the imaging space. Lung cancer has just been released, and that's only for a sector right now of patients. Hopefully for everybody, it's going to, be standard of care. But this is the only annualized imaging screening on an annual basis that happens around the world. And so there's tons of data, there's tons of information. That's why there's tons of innovation in the space. And the innovation that's happening in the space then gets to translate to everything else, and other areas and other disease states and other oncology. And so what we do here changes for everybody else and for other diseases. And that's really important for everyone to kind of understand. And there's tons of information and data.
Yeah, just so exciting. And, that's why it's amazing to have you guys on and have this conversation, and sure people are aware of it. I know, Celeste, when we were talking, you mentioned, I think, that cancer increases a stage every single month. So if you're stage 1 in January, if you don't get it diagnosed by February, you could be stage 2.
Yeah, 60 days are the stats
Okay.
I've always used. But it's if we think about it, 50% of women aren't even getting their screening, then 43% of those women aren't coming back to get additional imaging as recommended. We're not getting to that biopsy, for months, right? So national average now, from getting a biopsy to getting your results of that biopsy with any meaningful outcome, like what do I do with this versus just seeing it on my portal, is 21 days nationally. And then to get onto any type of treatment is another 53 days. So here they just continue to add up. And what I'm treating 2 months from now, 3 months from now, was not the cancer that I was diagnosed with. And it is a, thanks for bringing that up, Nicole, because we are going to see an influx, hopefully, of women participating in breast cancer screening and diagnostics. I love the route that Liz went with the diagnostic helps. It's not all about imaging. We need to reduce the amount of imaging. We need to have the right imaging at the right time. But how can AI and all of these other technologies really help us to help the radiologists? Because they're not 100% sensitive either. Like, they're going to miss some things, and because they can't see them or they're not using the right test. Not all the breast radiologists or all the radiologists who are reading breast are trained in breast. So that's where AI and these other diagnostics that Liz is talking about, the blood tests, can be so much more effective to do that. And, again, 99% survivorship, and it's not just surviving, it's thriving.
And there's not enough radiologists. They are retiring at a staggering rate. They're exhausted. And just imagine, like any one of us, like they're humans too. Like,
Right.
God forbid, their kid was up all night, or, they're really tired. Well, their tool is their eyes, and they're tired. Like, you know how we feel. Like, I'm wiped out today. And like, there's no way I could look at something on a screen and, have a coherent sentence either. But it's one of those, like, this is their tool. And so they're tired, or it's 4:30 in the afternoon, and they are sitting in a dark room reading black and white images, and they are exhausted. And so did you catch them at 9 a.m. when they're maybe a little bit more fresh? Did they just have coffee? Did they just have lunch? Are they tired? Is it 4:30? Is it this? Is it that? And this is where tech really needs to help them. This helps in the prioritization, because, look at the early cases when you're fresh, and you decide when you're fresh as a radiologist, that's a decision point. But having the CAD to say, hey, these are some areas of interest, having a prioritization of putting the harder cases, making sure that there's easy and accessible training for, so when you're a radiologist, you have to be additionally trained to be a breast radiologist and a breast certified radiologist. And it is incredibly hard to do it. So when you do get your breast mammograms and, do thank your radiologists, like they work really hard, not to say the others don't, but like there's additional training. And, there needs to be tools to make it, I don't know, maybe like a little bit more exciting for them too. Like we colorize the image, like the lesion specifically. And the feedback we get is like, oh my God, it's so nice not to be staring at just a black and white. Like we like the blues, like we like to see what's happening inside. And it's an aid. It just actually makes them more excited or interested and engaged. And like the blood test, they can feed into the information that it needs. We're talking about personalized care in the future. So a blood test, reading, your family history, knowing your genomics, like knowing all of these things and having, these imaging and having this and having multiple years of images is incredibly important. And having, AI and machine learning plugging into this and interpreting it, that's a help to a radiologist. You also have to understand, as new radiologists come into the field, well, they're new. We weren't great in our 20s, like probably at our, the job that we're doing now. And quite honestly, like we can't expect every radiologist at 30 years old to be the same as a 60-year-old with 30 years of experience. That is an unrealistic expectation. And so they need help. And that's where all of this starts to come in. And, we want the radiologists really to look like the really great ones and the heads of the department, like look at the hard cases. Anything that's an easy case, okay, great. Like that's easy for them. Give them the tools to look at the hard cases, the dense breasts, the ones that, had to have reconstruction, reoccurrences, all of these things, like give them tools to help them. They're humans.
Yeah, awesome conversation, you guys. And we're definitely going to circle back to those technologies that can, help improve protocols today and dig more into that for sure. But I don't want to skip over the idea of what women can do with this information that they're going to get now with the Mammography Quality Standards Act. They're going to get, notification if they have dense breasts or, say they get a abnormal mammogram. So just because they get these things, does it mean that, okay, Marissa, necessary additional screening is covered? So what are some of the challenges there? Like Celeste, can you talk a little bit about that? Like women are now going to be empowered, but what can they expect?
Yeah, unfortunately, they're going to expect a bill. Most of them. But Marissa's directly involved with this in the Find It Early Act and ABCD Act and mandating that insurance companies do cover these out-of-pocket costs for the necessary additional imaging as well as diagnostics. Because if you do find something, we need to have the opportunity to either do the additional imaging to rule it out, have the ability to add tech into this, and make it affordable for the facilities to even be able to implement these technologies. So, additional imaging is going to be part of it. Tech is going to be part of it. But unfortunately, right now, out-of-pocket costs are going to be part of it. And, it's been wonderful to see this change in screening that it is covered for women. But many of us are either underinsured, or if we have insurance, we have very high deductibles. And out-of-pocket costs can be in the thousands of dollars. And when we're only looking at some of these technologies for, and we're considering dense breast patients, that's every year I'm going back for that additional testing. My mammogram may be covered, but my MR wasn't. My contrast enhance is out of pocket. Even my ultrasound is, we think, as easy and accessible as that technology is. So it's, work like the Find It Early Act and those things, that it's going to be grassroots. There are wonderful resources out there. The Dense Breast Organization is fantastic. They have a ton of information. Women are going to have to go and learn themselves. And in many ways, they're going to have to teach their referring physicians because they're not going to know. And I'd love to see us do some more work on these notifications to make recommendations of what they should do versus go talk to your referring physician. You may need more. And the referring physician is going to be saying, oh, I don't know what to do either. So.
And we've received, you know, listen, all of us on this phone have received the notice, and it's, you know, because we're all in states that covered it previously. So, you know, the notice reads, you have dense breast, or you know, you have dense breast. We might have seen everything, but we might not have. I mean, I'm paraphrasing, that's obviously, but that's kind of the gist of the letter. Sometimes it tells you to get additional imaging, sometimes it does not. So you're like, oh, great, what do I do with this information? So yeah, my density matters is great. The Brem Foundation is great information. There's a lot of information out there. All of our organizations, I'm sure, you know, we talk about it a lot. You need to read up on it. You need to, and really you have to ask, you have to, you know, oh, I have dense breasts. Okay, according to the standards, that means that I should be having additional imaging. So I'm going to ask for it. And the problem is exactly what Celeste's saying. It is oftentimes out of pocket. I literally just had it 2 weeks ago, and we cannot penalize women who they actually might see something, and you're penalizing them monetarily for having to go back and actually taking care of it. So I needed to have a diagnostic mammogram and a diagnostic ultrasound because I have dense breasts. They could not, there was an area of concern. They had to see something. I had to pay for that. And, you know, I guess same as Celeste, not great insurance, let's be clear. And it's, but thank God I can pay for it. And thank God I can walk down the street because I live in Manhattan, and I can, you know, go to the best of the best at Mount Sinai, New York, and, you know, any of the other, you know, hospitals here. Somebody in rural Idaho with 2 jobs and childcare, that is not an accessible service. Let's just be very clear. And, you know, they cannot pay for it. Additionally, so we're very grateful. Just actually this week, it was introduced into the Senate, the Find It Early Act, and it's been it was in the House already, sponsored by Representative Rosa DeLauro. And you know, so we are grateful that there is now potential federal funding for federal employees, for DOD, for everybody, for total insurance coverage. It's not going to get passed in this Congress. It's going to hopefully be in 2025. And that would be a great outcome for all of us, quite honestly. But it is something that you need to plan for, and you need to think about, and you need to understand your risk, and you need to talk to your doctor about that. And maybe it's just over a chat, you know, with all of these functions, you can chat with your doctor, but have that conversation, do a little of education. And sadly, we have to educate ourselves. And, you know, as Elizabeth was saying, like, we have to educate sometimes our providers because, you know, like I keep saying, radiologists, regular doctors, they're just humans. Like, they can only have so much information at their fingertips. And sometimes they don't have all of this. And we as patients need to, you know, and as daughters and as mothers and as women and as friends, like, we need to tell everybody else about this and the resources that are available.
Yeah, I think that's really important. I mean, I go through this pathway every year. Last year, I went all the way through to biopsy. I had 3 masses, and I had a breast surgeon whose whole world is doing this. Tell me, no, you don't have to worry about having dense breasts. You really shouldn't be doing your ultrasound and MRI every 6 months. That's unnecessary. This is a breast surgeon, folks. She literally does nothing but breast cancer. So I cannot emphasize how important it is to, 1, be ready to find a new doctor if you hear somebody say something like that. 2, know that you are right as you sit in that room and say, hey, I just found out for the first time I'm category C or category D, and I know I need something more than mammograms, because if I'm category D, mammograms only 30% sensitive for me. I mean, 70% of the time it's wrong. That's not enough. I need something more. And this is going to be a real evolution, I think, of pieces of the patient-doctor relationship, because docs are just people. They cannot keep up with everything coming out. They cannot keep up with every act of Congress. They cannot keep up with every guideline change. So it's really important for companies like us to be advocating and making sure information is getting out there for these women. But the sad reality is you are going to pay. It actually took me 6 months to go from initial mammogram through to biopsy result, and I was out of pocket over $7,000. So yeah, we're going to pay. There's just no two ways about that. Again,
It's not accessible for most women.
yeah, and it just highlights how important simpler technologies are going to be in this care pathway, like blood testing.
Yeah. So let's get there. So let's talk about the innovations and how we're going to shake up this standard of care. Maybe not shake up, right? Improve, streamline. I want to hear more about the blood test. What does it do? How does it do it? Maybe not how does it do it, because that could get really technical, but how can women leverage this, right? And can they? When can they?
Yep. All great questions. So I always say, like, the one silver lining of COVID for us at Mammogen and our sister companies is now everybody knows what RNA is and everybody knows what PCR is, right? And so those are the two places where we eat, live, and breathe at Mammogen. We look at a subset of RNA markers, and real simple, RNA is like the language of your cells. It's what starts talking when something new is going on in your body. It's what has allowed us to really unlock true early detection. Most of the industry focuses on DNA, which has great applications for late stage questions, but not early, because you can't see the DNA till the cancer's already done its dirty work and died, right? So that by definition isn't early. But RNA is very different. We've found the markers that kind of chatter amongst themselves specific to breast cancer. We can detect it in its earliest stages, and we use PCR. PCR is our technology. And just like what everybody used for COVID testing. And PCR is wonderful when you're dealing with RNA. It is very sensitive. It is quite affordable. And you will hear me over and over again say, I think most of the diagnostics industry has done a lot of things wrong. I don't think anybody has been focusing on accessibility, scalability, deployability, and affordability. And if you're not hitting on all four of those axes, then you are doing a subset of the population a disservice. And PCR-based tests are wonderfully affordable and perfectly suited when you're looking at RNA gene expression. So that's what we do. We have a subset of markers. We know exactly where to look. Interestingly, the way we find our markers is really cool. So none of the markers in our tests have ever before been associated with breast cancer, but when they all come together and you start listening to their chatter, they're phenomenal at detecting early breast cancer. And our goal is to have the test in the market probably around this time next year. And it will be on, yes, yay. And the cost will be, orders of magnitude less than imaging. We're talking under $500. So these are all of the important things that people need to be talking about. And you need to know there are so many ways that you can improve your own outcomes simply by knowing just a little bit, being bold enough to ask the questions to your doctor, and keeping up with innovations like overlaying AI and what's happening in blood cancer testing or breast cancer testing in blood. And I always say, reach out to us. I mean, I answer every email from patients and women and advocacy groups that I get. And Cole, that's how you and I met, right? So don't be afraid to reach out to the CEOs of these companies. We want to hear from you. And we're very happy to give you the information you need.
Awesome. Thank you. I'd love to also hear from Celeste and Marissa. What innovations are you guys seeing that, we can potentially expect to help aid with diagnosis?
How long has it been that we haven't said the word AI? I mean, God forbid. I mean, the genies are probably, going crazy, but AI machine learning. And I know this is a question that popped up that I answered as well, but listen, AI is going to help streamline. AI is going to help visualize. That's very much what Deep Look does. AI is going to help to unlock a lot of the information that you can't see. It's going to be able to make predictions in the future. It's already starting to do that. We're going to be able to prospectively see, and hey, you have something here. It looks like in 5 years it's going to be this. Could be nothing. Could be something. This is the future. We're going to be able to knit together very quickly and instantly the information from your blood tests, the information from your microbiome, the information from your family history, the information, from past years of imaging, and maybe other things. Maybe you're knitting together some of your lung scans, and because you're seeing a lot of things on the chest wall now, and lung screening to start to pick that up. So there's a lot that tech and AI, and people are afraid of AI. It is a way to make things faster, more streamlined, and is a way to crunch information that doesn't have to be done, by people sitting in a very dark room in a lab. And that's what it is. It's computer code. We're all on our phones, we're all on the internet. This is what this is. So, I think that's very much the future. But we have to start with saying, these are augments, these are helps. And at this point, I don't see in the next 5 or 10 years that we're replacing radiologists. I do see in the future, 10 years, very easy scans. Yeah, it'll be read by an AI algorithm and probably spot checked by, by a human, by a radiologist. But this is why we want the radiologists to focus on the hard cases. This is what we need their eyes and their brains to do. AI can take care of, in this example, very fatty breasts that you can very easily see a cancer because it shows up hot white on a black image. Literally, that is easy to see, and anybody, can do that. That's where AI can help. But we're not replacing doctors at this point. We're just making things easier. We're saving them time. That's what all of this tech is. So I think that's where the future honestly is going. There's so much happening. There's, hundreds of companies working on this in the breast space. There's hundreds of companies working on this in the cardiac space. And I think this is where we all just really need to work together. And, the definition of AI for good, this is it. This is where we really help move health for everybody, especially in this case, women, forward.
Thank you. Celeste, anything you want to add?
Yeah. Did we say AI?
Maybe.
Not in the last 30
gonna...
seconds, so maybe.
Because it's already changed.
Right. Well, exactly.
Yeah. But it's true. We need to help our radiologists see better, see more, detect early. We need to help women who are actually participating in screenings to get better outcomes from them. So how can AI help with that? And the other piece is just access. The woman in Idaho should have the same access as Marissa does in New York City to technology that can help her. How do we make some of these technologies work better? We went from film to digital, which was the huge step for everyone to really see what they could finally see. When we went to Tomo, did the same thing. We can rule out a ton of things when we do that. We're now adding, contrast and technology into this that we can be more sensitive and more specific. We can see vascularity early before it gets to lumps where women are finding them themselves. And these are on systems that we can get out into the community for women that are relatively more affordable than some of the other big iron that we have that we want to keep for the hard stuff, right? Keep it for the hard stuff. But when we can, hit a larger population of women in the screening facility, I think we need some more of these sensitive based technologies that are affordable. And it's really some of the work that we've been doing around contrast enhanced mammography and how we get that out into the population more so, and then into a screening population and into a reimbursement mode.
All very important points. Thank you so much. We do have a few questions that came in, so I'm going to turn to a couple of those. Specifically, someone is asking, and I'm sure a lot of people want to know this, is there any technology out there that's going to be less painful than current imaging equipment?
Blood tests,
ultrasound. MRI is not very, hurtful. Listen, I developed the mammography systems. I did for many years. I was also part of the acquisition of this technology called the MammoPad, which, a million years ago, I understand, but, it's a pad that goes on. That's like literally a cushion that, doesn't obscure any of the imaging. There's things like that. It's also, a lot of it has to do with training of the rad techs. You get a really good rad tech, but you don't feel anything. You get, and let's just be clear, when you compress something, anything, even your finger, it hurts. But it's 30 seconds of hurt versus, years of potential death by cancer. I mean, I hate to minimize it because I actually am pretty desensitized to it, but I think it's, there are technologies, honestly, take an Advil. Take an Advil 30 minutes before, it actually helps. I'm sure there's other technologies I've actually seen besides the MammoPad, that's 100 years old and I don't think it's on the market, but there's other innovations that are out there.
It is.
Oh, wow. That's good to know.
Yes.
There's other innovations that are out there, such as those, and you can also ask your radiology technologist, to, what they are.
But there are also other things like around the technology. I mean, you talk about the equipment's necessary, but are there things in the equipment that we can make more ergonomic? So because we're talking women in tech, those are things that we've been looking at GE. Our latest system, the Pristina, was actually designed by women, engineered by women, and women who have used the equipment and understand the pain of compression, right? So how do we make this big iron smaller, softer, rounder, all these things that we can actually fit on our body versus having to contort our bodies to fit on the machine. So I think some of those is simple distractions. Let me do my compression myself. I can, it's like ripping off the Band-Aid yourself versus someone else coming and doing it.
Yeah, and this is why we need women in tech and women in engineering and women part of design.
Yes.
And, this is very much part of it. And, women in testing and, all of these things. And it's the feedback, everyone knows it's painful. But there's things that can be done to help, and having more women engineers, women in design could help.
Great, thank you. So I have a number of questions around, how do we get blood tests into the standard of care? How do we change the protocol? I don't think we have literally 2 minutes left, you guys. I mean, we could have a whole nother hour here, but I guess real high level, let me kind of wrap that up into how do we help inform change, right? Maybe if you could each just quick go around the circle, maybe as an individual, as a company, how can we help inform change and maybe, bring some of these technologies to become standard of care?
Yeah, I'll start. So I think the easiest, most practical way for us to stay informed is going to be on you, ladies. You're going to have to keep up, do your reading, Google Mammogen, Google blood tests for breast cancer. Make sure, when you have questions, reach out to the companies. Not all diagnostics are made equally, and there's some really important things to understand. We're happy to help you understand those. But the vast majority of it is going to be on you to make sure you're informed for now, until there are some pretty important changes that are coming. And we have some really exciting things coming at Mammogen. We're going to be partnering with some larger than life folks that everybody knows. And I think companies need to start doing that. I think we need to start partnering with industries where people are household names and they're in everybody's everyday life. That's the best way to get information out in this world. So those are my 2 cents.
I would add, kind of 3 things for people is don't be afraid to participate. We have to participate in this. And because it is curable, it's not curable, but I mean, the cancer is there, but you can live and survive and thrive. So don't be afraid to participate. Definitely advocate for yourself. We're probably the worst at it. We advocate for everyone else in our lives except for ourselves. And probably those of us in MedTech are the worst in compliance for their mammograms. I might be a little out of date. But the third one is communicate. Liz, you mentioned somebody who was 75 years old and had no idea about breast density. It is a key factor, and it's out in the media now, which is, thank God, people are talking about it. But breast cancer is so prevalent in this world. And we need to break a barrier of mental consciousness that we can't talk about it and that it's a bad thing. We need to communicate with our sisters, our friends, our wives, our partners. I always say, you could swing a cat and hit somebody who has breast cancer, knows somebody who has breast cancer, and can tell you about their experience. And those shared experiences are going to help us to move this forward.
Yeah. And lastly, well, 2 things. First of all, it's 1 in 8 women and trending to 1 in 7. So it's actually getting worse. And that's great because we're actually finding it earlier, not great that it's getting, but like we're finding it earlier, but it's also more aggressive. And there's so many, we can have a whole discussion about that. So, but I would say, to both of the ladies, yes. And there's 2 other things. We can legislate and help make that change and make sure it's covered. And the last would be innovate. Be part of the innovation, encourage women to be part of engineering teams and join women's health companies and make the innovations. And by the way, support the innovators. Make sure there is money for companies that are doing these innovations. And it's not just big companies. We are all Liz and I are at small companies. We need money and investment to move this technology forward so that it can get in the hands of somebody like a GE or a Hologic. Because there's a lot of innovation in tech that is dying on the vine because it is women's health and there needs to be money.
Wow, you guys, such a great conversation today. Again, thank you so much for your time. Marissa, Liz, Celeste, you guys are amazing. Thank you everyone who joined us live today. This was a great Women in MedTech Forum on updates in breast cancer diagnostics. Again, I want to say thank you to our sponsors for the forum this year. Best Buy Health, Medtronic, PA Consulting, and Sunrise Labs. So as I mentioned, this is being recorded. Everyone will get a copy of this. If we didn't get to your question, we will do our best to answer you via email because I appreciate all of those questions and they're very important. And I encourage you to come to massmedic.com/events and check out all our other great events we have coming up and save the date for our next Women in MedTech event. It's going to be live at Best Buy Health on December 4th at their new location in the Seaport. We're going to be talking about connected care from 1 to 4. So stay tuned for the registration link for that. All right, everybody. See you next time. Thank you.
Thank you.